Good morning, everybody. Yay, it's working today. Before we get started, and because Dr. Strauss needs to use his computer, I actually don't have the featured study slide up, which is regarding SCOUT, and I think Dr. Gessel is going to say a few words about it, right?
Well, without the slide, I'm not sure if I can do it, but no. So, I mean, Lisa made me come here a little bit earlier this morning. So SCOUT. So bottom line is this. We have a couple of devices now that give us the opportunity to treat severe tricuspid regurgitation. Obviously a hot topic and also difficult to treat. But if you have a patient with severe tricuspid regurgitation and you had issues with medical therapy, unlikely to be a surgical candidate, but let us worry about that, then you can refer him or she to our valve clinic as you always do, or when we do our valve consult service. And the SCOUT trial is a trial that investigates the so-called mitral line or tri-line device. For those of you who are familiar with cardiovascular surgery, and I had to learn about it, the old De Vega procedure, where basically no ring, but just a cinching of the valve into basically a bicuspid valve was done, is this procedure percutaneously, okay? We don't expect that this is the cure for all, but hopefully this is the procedure that at least gives you and the patient some medical options for further therapy and symptom relief. We don't expect zero TR from this, but at least that's an option. There's another option, of course, which is a different trial I'm not going to mention right now because we're only talking about the SCOUT trial today. But at least we have two options now. Anyway, just send them to the valve clinic or the valve consult service, and we will take care of the rest. One thing is just lower your expectations because probably only 20 to 30% of people that we refer to the trialists and reviews in New York will be accepted. So most likely 70% will not be accepted.
All right. I'm going to turn this on.
You're on.
Does this work? Can you hear me? Is that better? Good morning. I'm Craig Strauss. I'm one of the cardiologists with Minneapolis Heart Institute. And I also work on some quality and outcomes improvement through the cardiovascular service line through something that MHI developed called the Center for Healthcare Delivery Innovation, or HDI Center. I'm going to talk to you this morning about how we leverage data to drive quality improvements and innovation in care. See if we can make this. So I hope at the end of the morning you'll come away with a couple of things. One is an understanding of the growth of U.S. healthcare expenditures and how we need to make changes in how we care for patients to be able to continue caring for patients going forward. The second is to highlight the impact of unnecessary variation in care, and we'll give you some specific examples from our own data of unnecessary variation and how we've worked to eliminate unnecessary variation. And the third is to demonstrate the value of an enterprise data warehouse. How many people here have heard the term data warehouse? That's awesome. I asked that a few months ago at a presentation and nobody had heard of it. It's sort of a strange term, but we'll give you an example of how powerful it is. And at Alina and at Minneapolis Heart Institute, we're really lucky to have access to this data warehouse because it allows us to drive quality improvements in ways that other health systems can't. And it also gives us access to data that we can use for research purposes. So I'm going to start with some background. U.S. healthcare spending in the United States is astronomical, to say the least. It would be the fifth largest economy if it were measured by gross domestic product. Total healthcare spending in the United States was $2.7 trillion in 2011. It's continued to grow. It would be just behind those countries there. The U.S. is first, China, Japan, Germany, and then U.S. healthcare spending. That's a lot of spending on healthcare expenditures. And when you look at the return on investment from a very crude perspective, the blue bars represent life expectancy, and the red line represents per capita spending. And you can see for industrialized nations, many industrialized nations have similar per capita spending and better life expectancy than the United States, which stands out as an outlier on per capita spending here with relatively low comparative life expectancy. We often think that in Minnesota we're doing things better and we're more efficient and more cost conscious, but healthcare spending in Minnesota really mirrors national trends. We spend about $41 billion in 2013, and the Department of Health projects that growth of healthcare spending in Minnesota is projected at 7.8% per year. But what about cardiovascular disease? Cardiovascular disease is the leading cause of death in the United States, accounting for 17% of those national healthcare expenditures. It's predicted that by 2030, 40% of the U.S. population will have some form of cardiovascular disease. And direct costs are expected to triple between 2010 and 2030. That's shown in this graph here. Direct total cost of cardiovascular care will reach $818 billion in 2030. Well, what about variation in cardiovascular care? If you look at the cost of cardiovascular care, we realize it's very expensive, but the upper right here shows the underpenetration of specific diseases. So for example, on the second one in here, this is aortic valve surgery. And this represents the percent of patients that are under-referred for aortic valve surgery based on a variety of studies. And we're going to show that in our own data, that we're sitting on patients where we've done the echo and we've identified that they have severe aortic stenosis, and they may not be referred onwards, maybe even not from their primary care physician or from their general cardiologist to a valve specialist or to a surgeon. So we'll show that in our dashboard. And atrial fibrillation ablation, and we'll show that as well. There's another opportunity to improve penetration of definitive therapies for cardiovascular conditions. So variation in penetration of the use of the tools that we have. And then there's also variation in the way we care for patients. This map of the United States highlights inpatient hospitalization rates for atrial fibrillation. And what you can see is that the red areas are high areas of inpatient hospitalization for patients presenting with atrial fibrillation. And the lighter areas, the lighter colored areas, represent areas where there's far less inpatient hospitalization for atrial fibrillation. If you think in our own population, if you think when you're on hospital service, you probably see the same thing. A patient presents with new onset atrial fibrillation to the emergency room. Sometimes they get admitted to the hospitalist, they get a TE cardioversion the next day. Sometimes they get cardioverted in the emergency room. Sometimes they get put on metoprolol and sent for an outpatient cardiology consult. What's the right pathway and how do we identify the right pathway for patients? That's what we're trying to use the data warehouse to do. And then the last graph just shows that valvular heart disease is really a disease of our population, of those age 55 and older, and it grows significantly. And we're going to show some examples of our valve dashboard. So beyond the growing cost of cardiovascular care is the payment reform pressures. And there's tremendous pressure to change the way we get paid for health care. In 2016, CMS had 30% of payments were linked to what are called alternative payment models, quality, pay for quality instead of pay for volume. And by 2018, the goal is that that'll be at 50%, and that fee-for-service linked to quality will be at 90%. So we're getting paid differently, including the development of these things called accountable care organizations and bundled payments. MHI specifically and Alina has been approached by 4 organizations to have cardiovascular specific bundles, and we'll show how we use the data to prepare for that. But if you don't understand your population and how you're caring for your patients with common cardiovascular diseases, those undergoing CABG or those admitted with an acute MI, you're never going to be able to engage in bundled payments because you won't know how to reduce the costs, and you'll just end up losing money. So what about variation in healthcare? There are 2 types of variation in healthcare. The first is necessary variation. It's deviation from standard care based on individual patient characteristics. A patient has an allergy to a statin. We're not going to prescribe statins despite guideline recommendations. we use alternative treatments. Or a patient has a preference, doesn't want to undergo a specific procedure, and chooses not to proceed with aortic valve intervention, for example. The second type of variation in healthcare is unnecessary variation. And this is variation which doesn't result in a benefit to the patient and often is associated with increased costs. So when you think about the atrial fibrillation example, a patient presenting to the emergency department with atrial fibrillation who gets admitted for a transesophageal echo and cardioversion, their costs are, probably $6,000 to $8,000. A patient who gets started on a beta blocker anticoagulant and referred for an outpatient consult, their costs are probably under $1,000. And there are different reasons why you might do one of those, right, depending on the patient characteristics, those necessary variation. But there's a lot of unnecessary variation in that, and that's what we want to target. When you look across the country, the Dartmouth Atlas has done this, if you're familiar with the Dartmouth Atlas, that has looked at variation in physician practice patterns for many conditions, for PCI rates, for inpatient hospitalizations for atrial fibrillation, for a whole host of conditions. And you see this sort of similar map, which is the variation in care. If unnecessary variation were eliminated, these maps would look very similar in color. But the variation that you see across every condition highlights that unnecessary variation that we have in practice patterns across the country. And when they've looked at practice patterns across the country, higher cost regions have not been associated with improved outcomes. If they were, then maybe we'd say spending more is worthwhile. But when you look across a variety of conditions, across a variety of systems, higher cost areas are not associated with improved outcomes compared to lower cost areas. In fact, in many cases, the reverse is true, where lower cost areas have better outcomes. So this gets to one of the things that I think has been true in the work that we've done over the past several years, which is that quality improvement is the most powerful driver of cost containment. If we're focused on the fact that we spend too much for healthcare in the United States and we want to drive down costs without changing the care that we provide for patients, we need to focus on quality improvement. And that's what led to the partnership between Allina and Health Catalyst. How many people are familiar with the company Health Catalyst? Good. Health Catalyst is a data warehousing company that was started, I think, in part out of the partnership with Allina, and it grew to its own company out of Utah. It's a leader in enterprise data warehousing, and they provide the infrastructure for the data warehouse that we have at Allina through a 10-year partnership between Allina and Health Catalyst. And it's a really powerful and robust relationship that allows us to leverage the resources of a technology company in a way that a healthcare system would not otherwise be able to do. So it's been a very good collaboration. It's unique in the United States. Health Catalyst, I think, has maybe 40 or 50 health system clients in the United States. And I would say that Allina is among the earliest, if not the earliest of those, and the most developed in terms of its data warehouse infrastructure. So that health system collaboration between Health Catalyst and Allina, and then through MHI and our HDI Center, the goals are common. We want to improve quality of care and improve outcomes. We want to optimize publicly reported measures. We want to reduce costs where there's unnecessary variation, improve the patient experience, increase affordability, and improve the health of the community. So common goals leveraging data. This led to the development of our HDI Center, Healthcare Delivery Innovation Center. It's focused on reducing variation through standardized cardiovascular protocols, risk stratification tools, real-time decision support at the point of care, and innovative strategies for care delivery, including pursuing bundled payments like we mentioned earlier. And it leverages the partnership between Allina and Health Catalyst, which is a unique relationship that allows us to build these dashboards that I'll demonstrate for you. We wanted to be comprehensive in our approach, and so we've looked across the cardiovascular continuum, and we've tried to identify opportunities for cardiovascular care improvement across the entire continuum. In primary care, We started with a focus on lipid management. What patients are candidates for statin therapy that are not getting statin therapy in our current population, and how do we reach out and improve that care? And I'll show you some examples of that data. And we partnered with primary care folks to review that data and identify whether or not we're tracking the right outcomes. All the way up to inpatient and emergency services, the STEMI program, obviously a leader in the nation when it was initially developed. And one of the things that happened when it was developed was that every STEMI patient went to the ICU after their intervention. But you can really risk stratify those patients and identify the population that doesn't need to go to the ICU after their intervention. And we've done that, and we've been able to track those results. And then advanced therapies, TAVR, MitraClip, ECMO, all these things are powerful, powerful tools, and they're really amazing to see when you put them in the right patient. But how do you know who the right patient is? Who are the candidates that should get these interventions and shouldn't, particularly as the cost of these grow and we're under increasing pressure to rein in costs for healthcare? So we have 4 foundational pillars in the HDI Center. The first is to develop expertise in population health management, leveraging that data warehouse to understand our population of patients. Are we penetrating the population with the right interventions? Are there opportunities for growth, and how do we leverage data to identify those areas for growth? The second is to reduce clinical variation, and that's really reducing that unnecessary variation that we talked about. The third is to test new processes of care and payment models, and those for companies that are interested in bundled payments, that's a prime example of where we need to be prepared with our own internal data to respond to those requests, to be able to participate and continue to be leaders in cardiovascular care. And then the fourth is, how do you leverage the cutting-edge technology to apply it in the right subset of population or the right patients at the right time? If you look historically at the impact, and this is the impact of everything we do, this is not the impact of the HDI Center, but the HDI Center helps to quantify the impact of everything that all of us do at MHI at Abbott for cardiovascular care. It's about $37 million in improvement to Allina's bottom line through the changes that we have made in different ways. When the surgeons check the AFib protocol for their standard order set and allow the nurses to run a standardized protocol for postoperative atrial fibrillation, that's helping this bottom line. When the folks in the cath lab calculate a bleeding risk, identify patients who are high risk for bleeding complications, and choose to do something to try and reduce those bleeding complications, that's adding to this financial impact. But even more than the financial impact is the clinical outcomes that have been demonstrated. The ability to reduce intensive care unit days for patients who undergo TAVR procedures, the reducing ICU days for patients with low-risk STEMI that go directly to telemetry, getting rid of unnecessary lab testing, improving our supply chain optimization by partnering with industry to optimize how we utilize supplies and reduce the variation in supply utilization. So all those things have both a quality impact and a financial impact, and over these past several years, it's been a significant benefit to Allina from work that we've all done at MHI. So obviously, none of this could be done without a team, and the team is really these folks. There are data analysts, there are data architects, there are project managers. There's a whole host of folks in the background that help to run this data warehouse infrastructure and help us to understand where there's opportunity and where we can change things. And on the left here, Steve Bradley, who many of you know, who recently joined. Steve Bradley has been instrumental in adding to our ability to increase the bandwidth and increase projects through the HDI Center. So what is our data warehouse? The Allina data warehouse is 75 plus sources of information that are pulled together into a huge vat, spider web of data. And you can link them in many different ways. So when you think about our registry information, our STS registry following CV surgery, our TAVR registry following TAVR procedures, All those data points that are abstracted by nurse abstractors get put into this data warehouse. And we're able to then pull out specific characteristics and combine them with other characteristics. All the discrete information in the medical record, every lab value, every blood pressure, every temperature, every weight, all those things are entered into the enterprise data warehouse through the medical record, and we have access to them. And it's very powerful what you can pull out of it and build these dashboards to understand populations of patients. So 75 sources of information. The medical record is one of those sources of information. All of our registry data is added. Patient satisfaction data is added. And really anything that you can think of can also be added as long as there's one way to link it. So for example, if you have a patient's MRN number and anything else you want to add, we can link it into the data warehouse and we can add that information. Patients undergoing CT-FFR, for example, get their MRN number, get the data from the CT-FFR, we put that in, we can compare it to readmission rates, need for increased utilization or procedures following their CT-FFR. All those types of things can be linked together. And the data warehouse allows us to look in three categories of perspective. The first is retrospective, what happened in the past, and we did that with the bleeding risk score in the cath lab. When we looked retrospectively at bleeding complications in the cath lab and said they're a little bit above average, our transfusion rates are above average, what are the things that we can do differently? We looked retrospectively and we applied a risk stratification tool to identify high, intermediate, and low risk patients and try and apply bleeding avoidance strategies to those patients at high risk compared to those at low risk. That's a retrospective look. The real-time look is dashboards like the census dashboard, which you may never have heard of, but it tracks hospitalized patients across the Allina system on an hourly basis. So you can know, what their length of stay is, what their readmissions rate are. There's a tremendous amount of real-time data. And even the retrospective data is updated on a 24-hour basis. So the data warehouse gets refreshed every 24 hours with new data coming into the medical record and other things. Some of the data is refreshed on a less frequent cadence. For example, STS registry data or TAVR registry data is updated less frequently. But some of the data is updated every 24 hours, so you can see things grow on themselves. And when you look at a population of patients in year one, and then you do 1,000 PCI procedures over that year, and you look in year two, you've got a bigger population to understand what has been happening and what will happen in the future. And then the third bucket of opportunity is readmissions modeling and modeling potentially preventable events from predictive modeling. And there are some statisticians that work in partnership with Health Catalyst and Allina to identify opportunities for predictive modeling so that we can change care at the time they're in the hospital. So I want to start by giving some examples of how we've used the dashboard. And the first is the ACC-AHA statin guidelines. If I just said, what % of your patients are on appropriate guideline-directed statin therapy, how many would have a feel for the answer or would feel that the answer is good, is 90+% and we're on track? Right, we all think we're doing great. Yeah, we're all above average, right? Yeah, we're all above average. So one of the values of the data warehouse is to answer these types of questions. How many patients do we have and how many patients are on appropriate guideline-directed statin therapy? Thanks to Mike Miedema and the prevention team and sort of building out the clarity of this algorithm that's been sent around to a lot of people, we took this algorithm and we applied it to patients in our data warehouse. And so it was about 83,000 patients in the data warehouse. Let's see if this, the yes or no is whether or not they've been seen by cardiology. And so the first is correct statin. The guidelines recommended high intensity and the patient was on high intensity statin. That's this population of patients. The second column is the guidelines recommended high intensity statin and the patient was on no statin. And this eliminates things like allergies and all the things that we can eliminate. Now, it's not perfect, right? Some patients weren't documented as having an intolerance to an allergy. some refused it despite it, and they weren't listed as an allergy and stuff like that. So it's not perfect, but this is an area of opportunity, right? Guidelines recommend high-intensity statin therapy based on information we know about the patient in our own medical record, and they're not on any statin. And in the primary care population, that's about 7,000 to 8,000 patients. And even in our own cardiology population, this is across the cardiovascular service line, there's about 2,800 patients. And then you can go to the more detailed subsets. Maybe the guidelines recommended moderate intensity statin and they were not on a statin. That's this column of patients. And maybe there's overuse. Maybe the guidelines recommended no statin and they were on a statin. That's the target of potential overuse. And so this helps us to identify a population of patients where we may be able to change or improve care and improve outcomes down the road. Now, it's not going to contribute to that $37 million in savings because it's going to take a while to get these patients on guideline recommended therapy if they really are candidates for it after a more detailed review, and then to see the benefit of it because it's not an immediate turnaround, but it's a population health opportunity. Let me pause there. Are there questions about the statin data?
Is it possible to quickly add things like had a calcium score, result of calcium score, and other additive things that you can then direct to the individual physician to take a look at?
Yes, exactly. Absolutely. And that's the real power of it. The question becomes, how do we best reach out to improve the care of these patients? And giving additional information on what that patient has had or hadn't had. Maybe they had a calcium score of 0 and they should be in a different bucket. That's perfect information that can be added. And then we're working on what's the right way to reach out to patients or to providers, because giving a big list and saying you missed these 20 things is not a feel-good thing. It's not efficient. It's not the right way to go. So how do you give the information in a meaningful way to make changes? Okay, so the second thing is structural heart disease, and this gets to the management of patients, for example, with aortic stenosis and mitral regurgitation. And I'll ask the same question. How many patients do you think you have that have severe symptomatic aortic stenosis that haven't been referred for a valve procedure that might need it? Most people would say it's low, right? I mean, people who have severe aortic stenosis, of course, I am going to refer them on for surgical AVR or TAVR. Well, this is our valve dashboard, and this is going to jump into the actual dashboard, so I hope it functions properly. But this gives us a perspective on our population of patients with aortic valve disease and mitral valve disease. And specifically, we focused on patients with severe aortic stenosis and mitral regurgitation. And we pulled the data from our echo data, so the same criteria that we're using to diagnose aortic stenosis is the criteria that we're using for this. And so there's about 187,000 patients here with any type of valve disease. And I'll just, let me just click through a couple of things. If you look at patients who are up to date on serial echoes, for example, you can filter this down to aortic stenosis. It's severe. It's symptomatic. And across the system, let's just even go further, and we'll just look at MHI. So across the system, there are 1,000 patients who have echo documentation of severe aortic stenosis who have been seen by MHI, who, based on other medical record data, have characteristics suggestive of symptomatic aortic stenosis. And this is the percent of those patients that are up to date on their serial echo. But more importantly, if you ask Dr. Sun, have we done 1,000 aortic valve surgeries or TAVRs, the answer is no. This is an example of underpenetrance where there's a population of patients that have severe disease that we may not have reached out to. It's not 100%. We're not going to go out and do 1,000 valve procedures, right? But this gives us a starting point to identify well, what are the other characteristics why they might be excluded? They might have metastatic renal disease. They might have opted not to pursue intervention. But there's a portion of these 1,000 patients that we're sort of sitting on that are candidates for valvular intervention that haven't had that intervention. And then you can look at, well, what are the outcomes in our own population of patients who have the intervention and those that don't have the intervention. And so if this dashboard does a lot of thinking in the background, so bear with me. But if we just take patients with severe aortic stenosis, and we choose the ones that have not had a valvular intervention, and I could filter down to Abbott and all these other things, but the bottom line is that their one-year survival is in the 70-80% range. Sorry, this is their one-year survival. It's in the 83-84% range, right? For patients who have not had a valvular intervention, who we know based on our echo data and medical record data have severe symptomatic valve disease. The outcomes for those that have had intervention is dramatic. It's good. It's what you'd expect. 97% one-year survival for patients with surgical or TAVR intervention for aortic valve disease. So we can identify a subset of patients that maybe need an intervention, and we can think about what the best way is to reach out to those patients to get them in the right place. Again, not 100% of them need it. Maybe it's 10%. Maybe it's 5%. But there is a population of patients that we're sitting on that have aortic valve disease that may benefit from intervention. Let me pause there. And other questions about valve disease?
So, this is a reflection of not just valvular disease, but pretty much every therapy that we offer here, right? And the million-dollar question is, how do you capture these people? How do you move them in the direction? And there are many different, we've discussed various strategies in the heart failure, but the part of it is, how do you ping the physicians and ping the patients, so to speak, without giving the impression that you're trying to, quote-unquote, heal the patients. My thoughts and suggestions we have in heart failure is that the disease team that is looking towards it, so let's say it would be the structural heart team, has the infrastructure to drill down and then create an algorithm to get them back into the system and then ping and then respond back to the primary care or primary cardiologist to say, hey, listen, Mr. Smith has got X, Y, and Z. By this, he's got risk of, or she's got risk of this, and consider moving them on. Or at the same time, you let the patient do this, the same thing. So the idea is to get them involved themselves, let them understand what the risks are for where their under treatment is, and then, but still give it back to the primary care physician who still has control of the patient.
Yeah, so we've explored a lot of options, and I don't think there's a perfect option. It depends on the condition. When you talk to primary care doctors, they say, don't give me a list of I should do X, Y, or Z because I'm already covering so much stuff that I can't even keep up with it. So another list of this guy needs an echo or this guy needs a...
Right, that's the point. That's why the disease would be the structural heart that would take the ownership of this. And it would be heart failure that would take the ownership of heart failure type patients because the primary care physician, exactly, or even the primary cardiologist, 95% of what they're doing is, atrial fibrillation, hypertension, hypercholesterolemia. So they don't care about heart failure. I wouldn't say they don't care about it, but they're at least their focus on understanding what the state of the art for heart failure is probably, small.
Yeah.
And so what the care team that is actually primarily interested in this, like whether it's EP or structural heart or heart failure, would be the one to take ownership of this and help guide that therapy.
Yeah, no, I think that's a good point. We've started with Dr. Nickelbein and familial hyperlipidemia. We looked at the medical record. You can predict patients with an 85% accuracy of familial hyperlipidemia. We gave them a list of about 1,000 patients in the Allina Health system that meet those criteria. And in combination with the MHI Foundation, they're in the process of a letter directly to those patients after chart review to say, you may be a candidate for alternative interventions at risk for early heart disease, that kind of stuff. So, yeah, I think it's a disease-specific approach, but definitely we need to learn how to reach out to these patients.
Craig, I'm going to play the role of Ezekiel Emanuel, who's a health ethicist or economist, and I'm going to say, yeah, these are old people, and it costs too much. Valves are really expensive, so we're going to spend a lot of money, and we're not going to get a good return.
Well, I could filter this down to patients under the age of whatever you think is a reasonable return, right? You know, we could just go to patients under 60, but.
So is there an economic advantage of?
Yeah, so there is an economic advantage of intervening early, and let me see if I can pull it up quickly. If you look historically, I didn't do all these filters right, but generally speaking, this is accurate. If you intervene in a patient who has severe symptomatic valve disease in the early days, in the first 3 months that they have the symptomatic status, their 2-year downstream costs, excluding the procedure itself, are around $38,000. If you wait longer to intervene, the costs go up because of the rate of rehospitalization for things related to their valve disease. And so there is a cost to waiting beyond just you know, the benefit of the growth of the procedure and intervention.
By the way, I'm not a fan of it.
But like I said, you know, many grand rounds prior to this, I think Dr. Gornick said a dead patient doesn't cost much. So when you take it to that extent, it's hard to imagine that this is not going to cost a lot of money.
Well, it depends on what you're doing, right? The statin opportunity is not costly, but there's a patient population benefit to it. The valve intervention is costly, but the life expectancy change is significant. And you know, for other things like familial hyperlipidemia, it's sort of like your insurance company or your credit card company. You know, they reach out to you when they know you're about to have a life-changing event, right? You're going to have a baby and they notice you're shopping at Target buying baby monitors and stuff like that. So we need to be thinking a little bit more about reaching out to patients before they have the events that bring them into the hospital for really costly recovery procedures.
Oh yeah, I completely agree. But with the statin equation, when the statins were not generic, the cost was astronomical for, you know, every event that you have. You know, $250,000 to save one event, and how many patients needed to treat to do that?
Right. No, I agree. I think all of those
equation.
Thoughts need to be, and we need to be focused on each of these different conditions and how we intervene.
Going back to Bill's question, if you select the right patient, these patients, many of them end up having an intervention, but they have it late, and there's that additional cost. So you're right, you can do AVR on all 1,000 patients, but those who are going to end up having an AVR, if you do it soon and you identify them soon, you'll save some lives, but you'll save you'll save money as well.
Yeah, no, absolutely. I'll just give one other example, and then Roxanne is going to give an example of a pilot that we're doing. But I first want to highlight another way that this is used, and that's the way we use the data warehouse for cost differentiation. We looked at patients who undergo AFib ablation procedures at Abbott, and their utilization of healthcare resources in the year before they had an ablation procedure and the year after they had the ablation procedure, unrelated to the cost of the ablation procedure itself. And as you'd expect, they have far less ED visits, they have far less inpatient hospitalizations after they get AFib ablation. And then you say, well, how are we doing on the costs of patients who undergo AFib ablation? And if you look 2014 to 2017 in the Allina Health System, the cost of an AFib ablation, this is sort of a variable cost analysis, it's pretty stable. And you say, well, maybe we're doing okay, right? And people aren't, you know, using weird catheters and stuff like that. But if you dig a little further, there are high cost versus low cost sites. The left is the lower cost site where costs are around $10,000 to $11,000. And the right is another site where costs average $14,000 to $15,000. And then you say, well, what about even within those sites? And if you look within those sites, there's a high-cost provider in the high-cost site where they average $17,000 per case, and another provider within the low-cost site which averages $84,000 per case. Now, when you compare the outcomes, which we've linked to that, the outcomes are similar. And so the question becomes, is it worth spending $17,000 for provider A at site B to get the same outcomes that you get from, provider C at site D? And that's what we have to address, and that's what the power of the data warehouse to be able to answer some of these questions. I'm going to skip over this just to allow Roxanne to have a minute, but I think there are multiple other opportunities, and as you practice, you'll see that there are opportunities everywhere, and the extent that you can highlight those opportunities and share them with us, we can put the data around them to really learn and move forward as a practice. But things that we're piloting now, the ADHERE score for inpatients with heart failure, the CHF Bridge Clinic, which has been done over the past year, had significant reduction in readmission rates for patients who were seen in the Bridge Clinic compared to those that didn't. The low-risk STEMI patients not going to the ICU, the AFib protocol following CV surgery, the question of what's the value of a sternal plate versus wires in the closure of CV surgery cases, and the opportunity to risk stratify patients post-acute MI. You can risk stratify patients, and there's the patients that have a 20+% chance of readmission in 30 days, and then there are those that are low risk that have a 3 to 4% chance of readmission. Right now, we're treating those as one big bucket, and we tell everybody to come back in 3 to 5 days and to follow up with our MPs and stuff. We really need to be selective in targeting those high-risk patients and maybe just doing a phone call or an email or a text to those low-risk patients. So lots of opportunity. The key points are that healthcare market forces are driving an increased need for data analytics to improve population health and value, that our data warehouse is really nation-leading and allows us to provide data analytics support in a way that many other healthcare systems can't do to identify and provide optimal cardiovascular care, and that focusing on quality improvement really drives lower costs. And obviously, you need a team of everybody participating. So with that, I'm going to pause and ask Roxanne to come up. She's going to highlight an example of a pilot that we're doing around patients with depression screening for patients following acute MI. And it's something that we're doing as a pilot, but we're leveraging the data infrastructure that we have to understand how we can improve their care and then track their outcomes, their ED visits, their readmissions, and stuff like that. So I'm going to turn it over to Roxanne.
Well, thank you, Dr. Strauss. That was a great talk. And so this is not as technical as what your talk was, but I still think it's a very important project. So I'm going to be talking about a quality improvement project implementing a depression screening protocol in the MHI clinic for post-myocardial infarction patients. Just a little background, as Dr. Strauss said, cardiovascular disease is the #1 cause of death in the United States. That's not news to us. That's been that way for many years, and it involves both men and women. In 2014, there were 7.6 million people with MIs. 17.8% had a 30-day readmission rate with a cost of $693 million. This is by the Centers of Medicare and Medicaid Services information. Depression is 3 times higher in patients after an MI than the general population. So what is depression? It's a condition in which a person feels discouraged, sad, hopeless, unmotivated, or disinterested in life in general for more than 2 weeks. And this is the Anxiety and Depression Association of America's definition. Depression can affect the physical well-being, emotions, and thought process, and is strongly correlated with unhealthy behaviors. It is strongly associated with tobacco use, alcohol, drug use, inactivity, decreased drug adherence, decreased healthcare follow-up, and then as a result, increased use in healthcare resources, including ED visits and rehospitalization, as we said before. There's also a neurohormone effect that can cause increased biomarkers and inflammation markers. That could be why it increases the risk of coronary disease. Depression doubles the risk of death after a heart attack. This was an article that was printed in Heart Disease Weekly in 2017. It was based off of a study that was presented at the American College of Cardiology 66th Annual Scientific Session just this year. It was Dr. Heidi May, who's a cardiac epidemiologist in Utah, who reviewed 25,000 charts retrospective over a 10-year period looking at people with diagnosis of coronary disease, and she found that of those 25,000, there was a 15% rate of new diagnosis of depression, and then they had a 50% rate of death within that period, which was about a mean of 8.9 years compared to those without depression, which was about 38%. That was a significant difference. The American Heart Association, this is a statement from them, from a scientific statement in 2014. Depression after acute coronary syndrome is a risk factor for all-cause and cardiac mortality, as well as for composite outcomes, including mortality and non-fatal cardiac events. As such, depression should be elevated to the level of a risk factor for poor prognosis after acute coronary syndrome. That was in 2014. So needs assessment. The American Heart Association actually has recommended screening and management of depression in post-MI patients since 2008. They have guidelines of how to screen using a patient health questionnaire, 2 or 9. They have treatment management strategies as well. Yet, we are not screening for depression on post-MI patients in the cardiology clinic. Well, we say the primary care clinic is doing it. Well, the primary care clinic has gotten much better. They had an initiative a few years back, and they are screening on an annual basis, but it's people who come in for routine visits or for annual physicals. They don't screen people who come in for acute care. They don't screen after they've had an MI. And many of our heart patients don't follow with primary care on a regular basis. And even after they've had their MI and we tell them to go back to primary care, they might, but they still look at the cardiologist as their primary care provider. This is a flow chart of the depression screening protocol that we're going to be implementing for 2 months in the Minneapolis clinic and the West Health clinic. It's a pilot. So it's a clinical assistance that will be screening the charts, looking for patients who have had an MI in the last 12 months. And of those who have had a MI in the last 12 months, then they look under the health maintenance screen and see, have they had a depression screening, which for us will be the PHQ-2 or PHQ-9. If they have, that's it. We don't screen them again since their MI. I don't know if I said that. If they've not had a depression screening since their MI, then they would be triaged to our protocol. So the PHQ is actually a patient health questionnaire that's like 3 pages long, but what they have found is taking the first 2 questions is a strong indicator of whether or not there's depression, and if there is, then you go to the PHQ-9. It's the patient's answer on a Likert scale of 0 to 3 based on symptoms from more than half the days in the past 2 weeks, so they can go from 0, not at all, to 3 nearly every day. The PHQ-2, if they answer 1 to 3 in the response, then it automatically goes to a PHQ-9. By the way, this is in our EPIC, or in our electronic health chart. It's under flow sheets. It's very easy to access. I don't know if you can see this or not. Okay. So here's if they do answer positively to the first 2 questions, then they'll get this form, the patient will. And maybe some of you have seen this in the Alina Clinic if you've come in for routine visits or physical. So the first 2 questions are, in the past 2 weeks, have you been bothered by any of the following problems? Number 1, little interest or pleasure in doing things. So they can say 0 to 3. Or feeling down, depressed, or hopeless. Those are the first 2 questions. So if they answer no to both, screening is done. So some depression management strategies that I'm asking all of you in the cardiology clinic to kind of be aware of is if they like I said, answer negatively to PHQ-2, you're done. They follow up with their primary for annual reassessment. If the PHQ-9 score is less than 10, that would indicate some mild symptoms of depression. You'd give them, the RN would give them patient education. You would consider integrative medicine at this point for resiliency training or stress management. You just put in for a integrative medicine consult, and they will take it from there. And there is somebody from integrative medicine here at the Penny George and then also at West Health. And then follow up with their primary care provider within a month for a reevaluation, and then consider a cardiology follow-up in 1 to 3 months, depending on what the scenario is. If the PHQ-9 score is greater than or equal to 10, that would indicate major symptoms of depression. And then at this point, you have to be a little bit more aggressive. Consider initiation of a selective serotonin reuptake inhibitor, which, by the way, have been studied extensively in cardiovascular patients and have been found to be very safe and may even be cardioprotective. So there's a list on the management protocol that we have at the clinic of SSRIs to consider. Consider a mental health evaluation, and this can be done by ordering a consult with mental health, or it's called an e-consult, which is a little bit more complex, and if you order an e-consult, they'll get back to you within 24 hours with recommendations from somebody in the mental health field, but it comes to you. So if you order it, you have to deal with it. So it's up to you whether or not you'd want to do that. And I do have instructions on that, too, that I'll be emailing to all of you within the next week. And then they should follow up with their primary care provider within 1 to 2 weeks, and then consider closer cardiology follow-up too, because they do have increased cardiac symptoms when they're depressed. Question number 9, this is something that if they answer positively to this, you do have to pay attention, because it asks if they would feel that they would be better off not being here. So it's a suicide risk. So you ask them, do they have a suicide plan? If they say no, that they should follow up with their primary within a week, or mental health if they're already plugged in with them. If they say yes, then you need to talk to them a little bit more, find out what that means, consider an ED evaluation for admission. If they say yes, they feel that way, but no, they don't have a suicide plan, then talk to them and say, well, would you agree to get a medical help if you do feel like you're going to harm yourself? And so you have to kind of weigh, right? You have to assess the patient. If you feel that they are a high suicide risk and they're not willing to go to the ED, you could call 911 for their safety. All positive screening results need to be communicated to primary care by electronic documentation and or a phone call, and to mental health if they're already plugged in with them. So the aim of implementing this depression screening protocol is to increase awareness of depression as a risk factor for worse cardiac outcomes, and help identify symptoms of depression, and provide patients with evidence-based management strategies, improve patients' quality of life, quality of care, and outcomes, which would be that triple aim that Dr. Strauss talked about, improving population health and decreasing costs, and just to show we care. Oh, just questions and discussions. So I'll open it up for questions.
So I think this is a prime example of how we're trying to leverage opportunities to improve care with the data warehouse to track outcomes we're going to follow. Are there less readmissions? We all see the patient that comes back after a stent and has some twinges of chest pain, and we get a CTA or whatever. Are we going to reduce those types of outcomes by managing depression and anxiety in a different way? Great. As far as the natural history of depression by relative to time, because you may see someone a month later or a year, you might have significant communication of which like this.
Yeah, well, for this project, we're doing it for a year. So if they've had an MI within a year. So studies have shown that they have relatively high rates of depression immediately after the event. But then when they've looked at 4, 6, and 12 months, those rates don't go down. They stay up. So we think it's just because of the acute event, and it's, you know, it's a natural reaction, but very often it stays up there, and if we don't treat it, it stays there. So for this project, we're not doing it 2 years out. We're doing it 1 year out, but it's considered. Yeah.
What is the percentage, roughly, that patients have depression after MI?
Well, it's very variable, so 15 to 30%, depending on what you're looking at. So it is variable. It's at least 3 times higher than the general population, which is about 6.8%.
Should we just have a box with a check mark for Prozac right next to the beta blocker?
Well, it takes a little longer to take effect, and so I wouldn't necessarily I wouldn't use Prozac as a first choice, but. Zoloft is a good one to start.
Great session. Thank you both. I think the thing I want to ask a little bit about is, you and I have talked about this a lot, of how do we address these gaps where, for example, I'm sure I have a blind spot for valve disease, and there's patients in my practice that I should be sending to the valve clinic, and yet there are others who may have blind spots of who has heart failure that I ought to be seeing, and we all have our sort of chips on our shoulder about why don't I see more of this, and you know, I really struggle with how do we address this? How do we test strategies to figure out what's the best way? Is it a letter to the patients? Is it a letter to the primary care? I mean, any of these have their pitfalls, but it seems like this is maybe existential is a little too broad. This is really the problem for healthcare for the next decade, as I see it, is how do we figure out how to get people to the right care in the right place when we're managing a population. And so I'd like to hear more from you about what else could we be doing, what other ideas do we have, what other opportunities do you think we have? This seems like this is really a big deal.
Yeah, no, oh, sure. No, I agree. I mean, we are piloting a lot of different tests of how to do it. One is a letter to patient. One is list to primary care nurse managers that review things and then work with the physician to bring the patients in that need it for different interventions. One of the ones that I think is a new opportunity, which we're going to roll out over the next month or two, is a physician scorecard. And so all the data that I showed you from a population perspective is filtered down into a physician scorecard for you. So when you log on, it's going to say, here's your rate of statin compared to the guidelines. Here's your, and you click on the button, and it's going to bring you the list of patients. And so it's going to allow you to have a dashboard that manages the population that you're responsible for, and to then choose your own mechanism for how you do it, right? If you see that you're at 20% for statins or whatever, then maybe that's something you want to work on, and you develop a system to do that. Because I think part of it is going to be what works best for the clinician. All right, well, thanks for coming.
There's 2 forms back there.
Yes.
And I just need to stop the meeting and
Yeah.
everything.
Yeah, no problem. Thanks a lot.
Like totally what we're into right now in school and healthcare. For inviting me, you guys. Yeah, that's you. That's you. Thank you.
Yeah, no, thanks for doing it.
Thank you, Roxanne. Yeah, it's on the ledge back there. It says disclosure at the top. And meeting.